Okay, case one. A 32-year-old woman has an upper gastrointestinal endoscopy performed for the evaluation of unexplained iron deficiency anemia. She has no symptoms of esophageal disease. The endoscopist notes that the most proximal extent of the gastric folds is at 40 centimeters from the incisor teeth, and there is a tongue of columnar epithelium that extends to 39 centimeters from the incisors. Biopsy specimens of the columnar epithelium reveal intestinal metaplasia without dysplasia. Okay, you can see the endoscopic photograph there. What do we call this condition? Is this Barrett's? Is this intestinal metaplasia at the gastroesophageal junction? Is this carditis that's due to H. pylori, or is this a normal variant? So let me ask for a show of hands then. Who says this is Barrett's esophagus? Okay, a lot of people. Who says it's intestinal metaplasia at the gastroesophageal junction? Okay, a couple. Who says it's carditis that's due to H. pylori? We don't have any takers. Who thinks this is just a normal variant? Okay, nobody. All right, good. This has become confusing, okay? And what we have to say is that any intestinal metaplasia in the esophagus, if you're sure it's in the esophagus, no matter how little of it there is Barrett's. So the fact that this patient has this little tongue, yes, that is Barrett's esophagus. If we biopsied right here at the gastroesophageal junction, now you can tell that's the GE junction. Here's the top of the gastric folds that come up to this point. If we took a biopsy there and found intestinal metaplasia, we could call that intestinal metaplasia at the gastroesophageal junction. But all that means is we don't know exactly where the esophagus ends and the stomach begins. This patient clearly has columnar epithelium extending into the esophagus, and it's intestinal metaplasia. It's Barrett's esophagus. That's simple. You agree? Excellent. Okay. A 65-year-old man complains of long-standing heartburn. An endoscopic examination shows Barrett's esophagus with no other apparent mucosal abnormalities in the distal 10 centimeters of the esophagus. 4-quadrant biopsy specimens taken at 2-centimeter intervals reveal low-grade dysplasia. Flow cytometry is performed, revealing multiple aneuploid cell populations within the biopsy specimen. Dr. Souza, would you comment on the results here?
Right. So on the left, you can see the normal tissue with those peaks we talked about, the high 2N and 4N peaks. In here on the right-hand side is what you would get back with your patient with low-grade dysplasia, and you can see the arrows with those peaks that represent other than the normal 2N and 4N peaks. So the presence of aneuploidy within the biopsy would indicate an alteration in cellular DNA content, which again is it's not 2N or 4N. There's instability in the genome, instability in the DNA, and an increased risk of neoplastic progression, or all of the above. All of the above. All of the above.
Excellent. You can do that.
So the molecular changes that have been associated with cancer progression in Barrett's esophagus provide those cells with resistance to growth inhibitory signals, avoidance of apoptosis, resistance to cellular senescence, or all of the above.
Great. Okay.
Molecular biologist, all of you, thank you.
Yes. Okay, good. Which of the following is the best management option for this patient found to have low-grade dysplasia in Barrett's esophagus? Okay, so Dr. Souza's shown you these molecular abnormalities, but she also told you that we base our clinical decisions on the dysplasia. So even though the molecular abnormalities are probably more sensitive, maybe more specific, we still rely on histology. Low-grade dysplasia. So which is the best management option? Do you want to perform endoscopic ultrasonography? Do you want to perform endoscopic mucosal resection? Do you want to repeat the endoscopy within 3 months, take 4-quadrant biopsies at 1 centimeter intervals throughout the columnar-lined esophagus, or repeat the endoscopy in 1 year, take 4-quadrant biopsies at 1 centimeter intervals throughout the esophagus? Now let me just go back here for a second just to remind you of the case. This is the 65-year-old man. He has 10 centimeters of Barrett's esophagus. Biopsies were taken at 2 centimeter intervals, okay? And you've seen the flow cytometry. So, which do you want to do? Who wants to perform endoscopic ultrasonography? Anybody? Okay, we have some takers. All right, endoscopic ultrasonography, it's interesting in Barrett's esophagus. You know, what are the pros and cons? Initially, when people started doing endoscopic mucosal resection, they said, you have to do endoscopic ultrasonography. You need to do that to stage the procedure. You need to do that to look for lymph nodes. But in fact, it's been disappointing, the performance of endoscopic ultrasonography. It's not very good for these early mucosal lesions. So endoscopic mucosal ultrasonography has kind of fallen out of favor at this point. Who wants to do an endoscopic mucosal resection? Okay, somebody in the back. Okay, so a few people want to do that. That's not necessarily a wrong answer, but generally the recommendation is to do endoscopic mucosal resection only if there is a visible lesion. Okay? Now, the German group that has the most experience with this in the world hedges on this a little bit. And they say, yeah, we only do it if we see a visible lesion, but if you look hard enough, you can see a visible lesion in virtually everybody with dysplasia. I don't know if I believe that, but in this patient, there is no visible lesion, okay? So without a visible lesion, it's hard to justify. How do you know where to take your endoscopic mucosal resection without a visible lesion? There's 10 centimeters of esophagus. Where are you going to take that specimen from? Who wants to repeat the endoscopy within 3 months? Take 4-quadrant biopsies? Okay. Okay, that's very good. And what about the last one? Repeat the endoscopy in a year. Take 4 cents. Okay. You know, again, we've discussed this morning. I think you can make a case for either one of these things. I like option C because once you find dysplasia, the recommendation is not to take the biopsies at every 2 centimeters, as was done in this case, but every 1 centimeter. And you want to look very carefully because if there's low-grade dysplasia, there may well be a focus of high-grade dysplasia or even cancer hiding in there. So I would prefer to bring this patient back at 3 months rather than to wait for 1 year, okay? Okay, and especially with the findings that Dr. Souza just told you about. Now, do you know that this patient has aneuploidy in there? Would P53 add anything in this case?
There's no studies combining aneuploidy and P53. The only one was aneuploidy, P53, LOH, and P16 that I showed you out of Brian Reed's group. I think you're not going to see specific panels anymore. I think you're going to see those micro arrays or methylation arrays or mRNA arrays. So again, I'm not sure what recommendation to give you to act on it.
Do you know why the British Society of Gastroenterology chose P53 rather than aneuploidy?
So if any of you have gone to your path lab where they're doing flow cytometry, and they do this for liquid tumors all the time, the flow cytometry machine, you need an operator to program the normal parameters. What's the cutoff for each of the 2N and 4N? So there's a little bit of subjectivity. Brian Reed has the best data because for the last 10 to 15 years, he's had the same guy performing the calibrations on the flow cytometry machine, so he's very consistent. If you try to bring this into clinical labs and you've got different guys programming the flow cytometry, you're going to get different results. The automated image cytometry, which I mentioned, does the same thing as flow cytometry. Now it's all automated, so the computer can program it in. You can do it on slides after you've gotten your biopsy, so they can actually do aneuploidy on that. I think if we're going to see aneuploidy come out, the automated image cytometry is going to take out the variability. P53 immunohistochemistry, your path labs do immunohistochemistry for all kinds of markers, right? For breast cancer, they're doing estrogen receptor positivity, PSA. So regular clinical path labs can do immunohistochemical staining. That's why I think British Society picked immunohistochemistry. If you talk to pathologists, Robert Odds, who's a well-known Barrett's pathologist, there's a lot of subjectivity in P53 immunohistochemistry. And you're going to look for a positive stain by and large, and that's going to indicate a mutated P53. But again, it's just ease of having the procedure done standard in all clinical labs. Also FISH. The Mayo Clinic always talks about using FISH, again, because you can reproduce it.
It's interesting. Dr. Souza and I were at a conference over the summer, just to return to this issue of the endoscopic ultrasonography. Now, the conference was sponsored by the AGA, but it brought in Barrett's experts from all over the world. And I was actually very surprised that they recommended against using endoscopic ultrasonography for the routine evaluation of these cases, even if you're going to perform endoscopic mucosal resection and RFA. They said, don't do it. And we tried to make an argument, well, what about lymph nodes? You can see lymph node metastases, you can biopsy them. And they felt it just was not necessary. And as a blanket recommendation, they generally said, no, don't do endoscopic ultrasonography for these early lesions. Now, for cancers, it's a different story, but for early mucosal lesions, they said endoscopic ultrasonography had very limited utility. All right, in this patient, they chose the option of endoscopy within 3 months. Now we're taking 4-quadrant biopsies, this time at 1 centimeter intervals. So routinely in Barrett's esophagus, we take the biopsies every 2 centimeters. Once you know there is dysplasia, they recommend doing it at 1 centimeter intervals. Once again, a number of foci of low-grade dysplasia are found. Okay? So we know this patient has verified low-grade dysplasia now. So 2 times we've seen it. Dr. Souza showed us the flow cytometry saying there's aneuploidy there as well. Which of the following is the best management option at this time? So your choices are RFA, photodynamic therapy, esophageal resection, or have the biopsy specimens reviewed by another expert pathologist. Okay? See a lot of people, okay, you like the number 4, I agree, okay? And that's the general recommendation, is no matter how good you think your pathologist is, get this diagnosis confirmed by another expert. I find in general, gastroenterologists think the pathologists who are practicing in their hospital is wonderful, and they may be, but we see a lot of disagreement amongst pathologists in this diagnosis, especially low-grade dysplasia. Lots of disagreement here, so I would certainly agree, get it reviewed by another expert pathologist. The biopsy specimens are reviewed by another expert pathologist who agrees with the diagnosis of low-grade dysplasia in Barrett's. Okay, now what do you recommend? So now we have a confirmed diagnosis. 2 pathologists agree. Yes, it's low-grade dysplasia. Dr. Souza tells us there's aneuploidy in there. This sounds like something real. What do you want to do? Who wants to do esophageal resection? You want to take out the esophagus? Who wants to do photodynamic therapy? No, we don't do that one anymore. Too many complications. There is a randomized control trial showing that photodynamic therapy is effective in preventing the progression of high-grade dysplasia in Barrett's esophagus. But with photodynamic therapy, at least a third of patients develop very difficult to treat esophageal strictures, okay? So much higher than the 5% rate of stricture development with radiofrequency ablation. In addition, it's a very time-consuming therapy. Patients are given this porphyrin, photomer, and that means that once they've gotten that injection, they can't go out in the sunlight for 3 months because they now have this stuff in their skin, and they become very photosensitive. And you can't use sunblock like you would use if you want to go and get a nice suntan at the beach, because this is a chemical that's activated by visible light, not by ultraviolet light. So we've pretty much abandoned photodynamic therapy with some minor exceptions. We don't use photodynamic therapy anymore for treating Barrett's esophagus. Who wants to use radiofrequency ablation? Okay, good. Who wants to do endoscopic surveillance every 12 months? Okay, so we're about equally divided on that. And I think that's generally the way the world is right now, probably equally divided on this issue. But just let me show you some data on why we're so divided about what to do about low-grade dysplasia in Barrett's esophagus. Here's a study from the Netherlands. This study looked at 147 patients who had a diagnosis of low-grade dysplasia made at non-university hospitals. So this is from all over the Netherlands. They find 147 cases of low-grade dysplasia. They got the pathology slides and had them reviewed by 2 expert pathologists. Those expert pathologists confirmed the diagnosis in only 22 patients. So they agreed with the local hospital only 15% of the time. In 125 patients, 85%, they did not confirm the diagnosis. In 110, they read no dysplasia, 14 indefinite, 1 high grade. Now, does that mean the university hospital pathologists were right and the non-university were wrong? We don't know. We don't know that. All we know is it means they disagreed with the diagnosis from the local hospital many times, most of the time. Now, this study said low-grade dysplasia in Barrett's esophagus is overdiagnosed, and that's clear if you believe these data. It's overdiagnosed. The title of that report also said low-grade dysplasia in Barrett's esophagus is underestimated as a cancer risk. Because if they looked at the follow-up, the cumulative progression rate to high-grade dysplasia or cancer, for these patients in which the pathologists agreed there was low-grade dysplasia, look at that enormous rate of progression to high-grade dysplasia or cancer by 10 years. That looks as bad as the data for high-grade dysplasia. So in this series, low-grade dysplasia was a very strong predictor for progression. All right, that's one study. Look at this study. This is results of a large multi-center U.S. cohort study, 210 patients with low-grade dysplasia. They're followed for a mean of 6.2 years, and 27 developed high-grade dysplasia or cancer. This is an incidence of only 1.8% per year. The kappa value for agreement on low-grade dysplasia among pathologists was only 0.14. That's not much better than what you would get by flipping a coin and asking if you agree. Okay, so that's a terrible rate of agreement. And in this study, the consensus among pathologists in the diagnosis of low-grade dysplasia was not associated with progression to cancer. So we have these very disparate studies. I mean, one says you're getting 85% rate progression to cancer by 10 years. This one says it's really not very bad, and we can't make the diagnosis anyway, so why worry about it? So that's the situation we're in with low-grade dysplasia. And I think the test that Dr. Souza was talking about, earlier today, either the flow cytometry or P53, I think that might make a difference at some point. Yeah.
Since this is our only biomarker case, was anybody surprised by that meta-analysis? Not a meta-analysis, the modeling that I showed you. If you had 100% specific and 100% sensitive biomarker, you did not reduce cancer deaths. Doesn't that seem a little like, that's like the holy grail, right? That's what we're trying to, any thoughts on why? Why would that happen? 100% sensitive, 100% specific. Well, I talked to John Inadomi, who modeled that model, and it goes back to why the British Society picked P53 immunostaining. There's going to be inherent variability in any technique that you're going to use to detect your biomarker. So your biomarker is going to be great. The biomarker itself is great, but the technique that you use to detect it is going to have the inherent variability, and that's going to reduce its performance. So flow cytometry, if you do it worldwide, you're not going to get the same performance that I showed you in the studies with Brian Reed. Automated image cytometry is going to cut down on the variability. P53 immunohistochemistry is still going to have variability, so the performance is not going to be the same depending on where you have the test done. That's been one of the limitations with the biomarkers. I think perhaps these panels, which are going to take out any kind of variability in the performance, might show the improvement. And I think that's kind of what we're waiting for before we implement one of these biomarkers.
Very nice. By the way, if anybody has any questions at any point, please don't hesitate. Raise your hands. We'll be looking out for you there. Okay. We have a question here.
Mi pregunta es, la metaplasia, la displasia de bajo grado o la displasia de alto grado, ¿en algún punto pueden ser reversibles? Y si es así, ¿cómo se puede diferenciar de la discrepancia diagnóstica entre patólogos?
Do you want to handle that? Do you hear? Oh. So the question is, can dysplasia, low-grade or high-grade dysplasia, can it regress and go away? And can you tell the difference between that and just disagreement amongst pathologists? Is that correct? That was your question? Yeah. What do you think?
No, so if it's, as I showed you, if it's really true low-grade dysplasia and you're going to have loss of a gene on a chromosome, you're going to hack off an end of a chromosome, for that to be reversed, you can't do that. I think when you find low-grade dysplasia and you do a repeat biopsy and then you don't find it and then it seems like it's reversed, I think it's sampling error. I think you missed it. You may have found the only locus there was of it. Indeterminate for dysplasia and severe inflammation can make the pathologist give you that call of dysplasia, but that's, again, subjective, as you can see by the kappa values. I think if it's true low-grade dysplasia with those genetic abnormalities, you're not going to be able to reverse it with ablation.
It is interesting when you look at the studies, though, in these sham-controlled studies, that patients in the sham group who had very well-documented high-grade dysplasia are not found to have it on a subsequent endoscopy. Now, I think Dr. Souza is correct. I also don't think that can regress spontaneously. We don't know that for sure, but it seems unlikely. But more likely, biopsy sampling error is a huge problem in this condition. You have 10 centimeters of Barrett's esophagus in this patient. You know, where did that sample showing high-grade dysplasia come from? It's not always the entire esophagus that's involved. So it's an excellent question.
And the kappa value?
Yeah.
The kappa value for pathologists being in agreement for high-grade dysplasia, which I thought all these guys should be, 1, it's actually not. It's quite low even for high-grade dysplasia. So I think that's where you're going to get this variability and this reversal of what they call.
Okay, very good. Let's go on to another case. 61-year-old man has an endoscopic examination for the evaluation of chronic heartburn. He is otherwise well. He's found to have columnar epithelium starting at 30 centimeters from the incisor teeth and extending to the gastroesophageal junction at 38 centimeters from the incisor teeth. So 8 centimeters of Barrett's. A nodular area is noted at 37 centimeters. I guess that's this nodule here. 2 esophageal biopsy specimens are taken from the nodular area and show specialized intestinal metaplasia with a single focus of low-grade dysplasia. This finding is confirmed by a second endoscopist. And actually, what's that? I'm sorry, pathologist, right? And I just wanted to point out one thing on the biopsy specimen showing the low-grade dysplasia. I like this particular biopsy specimen because, if I can get this to stop, if you look at this side of the biopsy, the left side of the biopsy is a normal, well, This is Barrett's without dysplasia. Look at these nice tiny nuclei lined up right along the basement membrane versus this, the dysplastic side. Here the nuclei are all over the place. They've lost their polarity and they're hyperchromatic. Okay, you can see the difference here between dysplastic and non-dysplastic in one biopsy specimen. Okay? Which of the following is the best management option? So here's a patient with 8 centimeters of Barrett's, little nodule there, low-grade dysplasia. What do you want to do? Options are to perform photodynamic therapy, radiofrequency ablation, esophagectomy, endosonography, or repeat the endoscopy within 1 month. So, anybody want to do photodynamic therapy? Now we trashed that one. Okay, we said we're not doing that much. Do you want to perform radiofrequency ablation at this point? Okay, we're not getting any takers on that, and I think that is correct. Do you want to refer this patient immediately for esophagectomy? Well, not necessarily. We still don't know exactly what we're dealing with here, what this lesion is. We just talked about how endosonography for determining the T stage of neoplasia is very unreliable. Yes, we have some, okay, so, sorry, I thought you were asking a question. You like the last option, which is to repeat the endoscopy within 1 month, take 4 quadrant biopsies at 1 centimeter intervals, and perform endoscopic mucosal resection of the nodular area. Yes, sir.
Quisiera saber, en este caso específico, yo sé que no es una displasia de alto grado, pero ¿no sería una opción hacerle una resección mucosa focal y después hacerle radiofrecuencia?
Yes. Okay, that's exactly correct. Remember from the history I gave you here, there's 8 centimeters of Barrett's. Whoever did this endoscopy took only 2 biopsy specimens. That's clearly not enough, right? That's clearly not enough. And not only that, when you see a nodule in Barrett's esophagus, that is when you are supposed to do endoscopic mucosal resection. So the fact that you have this very well-defined nodule, tough to get this to work correctly, but you can see the nodule in the foreground. That is something that should be resected. We should do the endoscopic mucosal resection, okay? That's the nodule I'm talking about. We should do an endoscopic mucosal resection and find out if that is showing invasion into the submucosa, then endoscopic therapy is not an option. Okay? If it's in the submucosa, then the treatment becomes surgical. If there's not submucosal invasion, then we can at least consider doing the endoscopic therapy. And in this patient where we have 8 centimeters of essentially unsampled mucosa, we just don't know. So the option of repeating the endoscopy, getting these 1 centimeter intervals, and performing the endoscopic mucosal resection does all the things that you just commented upon. A question in the back?
Sí. El problema con los nódulos en esófago es que uno no sabe qué tan profunda fue la biopsia para encontrar el grado de displasia adecuado. Probablemente las biopsias en el nódulo fueron superficiales y mostró en la parte superficial una displasia de bajo grado, pero no sabemos si más profundo en el nódulo hay una displasia de alto grado o un adenocarcinoma, porque el nódulo sobre Barrett es muy sospechoso. En esa óptica, y de acuerdo con usted con lo que dijo antes, sobre lesiones muy pequeñas de la mucosa, el ultrasonido endoscópico no sirve porque no se ve, pero sobre nódulos yo sí estaría de acuerdo en hacer un ultrasonido endoscópico, porque uno no puede estar seguro de que lo que está viendo es solo una lesión superficial y de pronto uno tiene más bien una lesión más profunda que llega y compromete la submucosa.
Right. And you're absolutely correct that mucosal biopsy specimens will not go deep enough often to make a diagnosis here. So the mucosal biopsy specimens are of limited value. If they show you cancer, okay, that's fine, but you may easily be missing it. The point that you make about the endoscopic ultrasonography, the experts would disagree with you on this. I'm not an endosonographer, okay? But the experts on this disagree. Their point is that by doing endoscopic mucosal resection, you are resecting into the submucosa. And if that lesion is going into the submucosa, then you know that you can't do endoscopic therapy. Now, perhaps your endoscopic ultrasonography would show you that it's invading right through the adventitia, but by doing an EMR, you will know that that is not a lesion that you can cure endoscopically. So the fact that you get the submucosa in the endoscopic mucosal resection is adequate to tell you whether or not you can even consider an endoscopic cure. You know, you can make the point that you want to look at the rest of that esophagus and look for, you know, how thick is the mucus, you want T-stage, but the fact of the matter is that endoscopic ultrasonography as a T-staging tool has been very disappointing. It's very good for the advanced cancers, but not very good for the non-advanced cancers. And as I was mentioning, this conference that Dr. Souza and I were at, these experts in endosonography said, we don't use it. You know, it's probably not useful in a lesion like this one. And so all I can tell you is what the experts are saying on it. Okay.
Part of what they were saying too at the conference is that inflammation, which can happen in the early cancers as well, surrounding inflammation, is going to obscure the planes. So you can't tell if it's invasion versus just inflammation. And also, inflammation can give you reactive lymph nodes. So if you're going to look at the lymph nodes around there and they look big and different, they say inflammation can do that as well. And I think we had that confirmed with our surgery colleagues most recently.
Yeah, of course, they make the point that you can do an endoscopic biopsy of those lymph nodes, but even that was confusing. So the consensus among the experts at this conference, which was just last August, was that endoscopic ultrasonography was not helpful in these cases. Okay, and here we go. Endoscopy is repeated within 1 month. 4-quadrant biopsies are taken at 1 centimeter intervals throughout the columnar-lined esophagus, and endoscopic mucosal resection is performed of the nodular area. Biopsy specimens of the flat Barrett's epithelium show several foci of low-grade dysplasia. The mucosal resection specimen shows high-grade dysplasia with possible intramucosal carcinoma. Foci of low-grade dysplasia are present in the resection margins. And just like you said, absolutely. Now, which of the following is the best management option? Okay, photodynamic therapy, we said it's out. Do you want to do radiofrequency ablation, refer for esophagectomy, or just perform endoscopic surveillance? Okay, I think at this point, as long as we are not showing submucosal invasion here, and we've adequately biopsied this area, then we would be justified in doing radiofrequency ablation of the remaining Barrett's epithelium. Okay. Now, we will end before 4. Radiofrequency ablation of the remaining Barrett's epithelium is performed using the Halo 360 device. That's that balloon-based device that I showed you, right? That's the 360, meaning it's 360 degrees. It's a circumferential ablation. Repeat endoscopy is performed 2 months later, at which time several foci of columnar epithelium, all less than 1 centimeter in diameter, are seen in the ablated segment. Which of the following is the best management option? And by the way, since this slide was written, the company that makes this was Barrett. It's been bought out by Covidian. I think they've changed the name, but it's the same idea. I don't think it's Halo anymore. I forget what they call it. But at any rate, it's either a 360 or 90-degree device that we use. So what do you want to do? You refer this patient for esophagectomy because you have foci of columnar epithelium. You repeat radiofrequency ablation using the Halo 360 device, or perform radiofrequency ablation using the Halo 90 device, or perform that. That's the one you want to do? Okay. Yes, so I agree with you. This is a good case for the Halo 90. This is just a little paddle-shaped device, and it's very good for getting these focal areas. Again, the 360, we don't want to burn 360 degrees for 3 centimeters in a patient who just has little foci of dysplasia. So we can ablate those foci using the Halo 90 device. So, radiofrequency ablation is applied to the columnar foci using the Halo 90 device. A repeat endoscopy 2 months later shows complete eradication of the Barrett's. Now what do you do? Okay, do you recommend endoscopic surveillance at 3-month intervals indefinitely? Endoscopic surveillance in 6 to 12 months? Endoscopic surveillance in 3 to 5 years? Or you don't need endoscopic surveillance anymore? Okay? Do we have any takers? 3-month intervals indefinitely, meaning forever? 6 to 12 months? Okay. 3 to 5 years? Okay. Anybody say it's no longer necessary? No. Okay. This is a very unfair question since there are no data on how frequently this should be done. But this is a huge issue. Virtually everybody agrees that we need surveillance. Okay, I showed you the problems with the buried metaplasia and with recurrence, but we don't know how to do it. Here's the proposed endoscopic follow-up, and this is just proposed. This is not verified in any kind of study, but this is what has generally been proposed. After you have achieved complete eradication of high-grade dysplasia, then we do endoscopic surveillance every 3 months for the first year, then every 6 months for the next year, and every year thereafter. That's the current recommendation. This is not a societal recommendation. This is just expert opinion. Thank you very much for your attention. We'll see. Oh, I'm sorry, one question. One question before. Yes?